with air. Hold it. Breathe out through your mouth. One final time. Breathe in deeply through your nose. Hold it. Breathe out through your mouth. Let your shoulders drop. Let your mind settle. And let your spirit open to what this new week brings. Now, breathe in again, deeply and intentionally. As you exhale, imagine releasing the residue of last week. The frustration, the fatigue, the uncertainty. You are not what happened before this moment. You are becoming what God is unfolding right now. Inhale, renewal. Exhale, release. Feel the rhythm of your breath align with the rhythm of grace. Every inhale is a reminder that God still breathes life into you. Every exhale is an opportunity to let go of what no longer serves your peace. As you sit here, say silently to yourself, this week is a new week. This is a new beginning. This is a new opportunity to grow, to trust, to rise again. Allow these words to echo in your heart. Let them find space in the parts of you that feel heavy or uncertain. Now, picture yourself standing at the edge of a sunrise. The light touches your face, warming you with promise. The shadows behind you begin to fade, and ahead of you there is hope, fresh and alive. Scripture reminds us in Isaiah 43:19, behold, I will do a new thing. Now it shall spring forth. This moment is your spring forth. This breath is your new thing. This week is your sacred opportunity to begin again, not in your own strength, but in divine grace. As you prepare to step into this week, whisper this affirmation within. I am open. I am ready. I am renewed. Let that truth rest on you like sunlight. Let peace cover you. Let hope rise within you. Now, let's take one final deep breath in. Hold it and slowly exhale, releasing every old thought and every old fear. You are here. You are whole. And this is your new beginning. Have an amazing day.
Good evening, everyone. We're so glad to have you be a part of tonight's cancer conversation. This is an amazing opportunity for us to come together and learn what is going to be impactful for our lives as we look at this area of oncology and pathology. We have the amazing opportunity today to be joined in conversation with one of the foremost leaders of research in this area. I am honored today to introduce to you an amazing young man who has spent much of his life focused on this area. Dr. Clayton Yates is a recognized expert in the area of health disparity. He earned his PhD from the University of Pittsburgh School of Medicine in molecular pathology, as well as a certificate in training in tissue engineering and regenerative medicine from the McGowan Institute of Regenerative Medicine, and went on to do some postdoctorate work at Emory University. And then um, did some professorship at the amazing Tuskegee University. And now he is at Johns Hopkins, and he's going to tell you a little bit more. But it's not about me, it's about him and the impartation he's going to give us tonight. So without further ado, I introduce to you my brother, Dr. Clayton Yates.
Thank you so much. Thank you so much. I'm so happy to be here. Thanks for that wonderful introduction. It has been a journey to get here, from Tuskegee to Maryland, and especially as it's getting a little dippy right now. I think about, I was actually in Georgia at a breast cancer event this weekend. It was nice and 75, 80 degrees, and it came back, it was a little chilly. But I'm happy to be here at Johns Hopkins, where I am the inaugural John R. Lewis Endowed Professor there. And so that allows me to do a few things, and that's helpful. Hopefully, that I'll share with you today, and we'll have time for discussion. So, I think this also wouldn't be, I wouldn't be here without my sister, Carmen Satchel. Carmen said, "Look, you got to come speak to our team and our group." She hooked me up with Mr. Bradford, and here we are. So I also want to shout out to Carmen. I know she's on somewhere. I saw half my family on here in some ways, so I know she got them all to join. So I'm really excited to share with you guys some of the work that we're doing, and it really starts. Particularly because of the experiences I had in my community and my family. So just to share a little bit before we get started, my I started my journey and we're going to talk about breast and prostate cancer. Also too, Mr. Bradford, I can't share. Can you allow me to share? We're going to talk a little bit about, breast and prostate cancer, but, my journey in this started when, I was very young, when my grandfather passed of prostate cancer, and I really didn't know why he passed, right? And so I was a teenager at the time, and, that really shook me. And sought out on a career of asking questions as to why. Now, that's also translated into my grandmother, his wife passing, who actually had breast cancer. And I didn't realize at the time she was clearly a survivor, but I grew up with her being a survivor. And then, but she ultimately passed of colorectal cancer. And then, before I left Tuskegee, my dad's mom, passed of pancreatic cancer. And, that was, a bit devastating for our family. And then when I moved to Maryland, my aunt, who I was very much looking forward to having a relationship, lived here in Bowie, and always got along well, and was really excited about becoming to Maryland. Is going to, you know, have a really great time. End up 3 months after I was here, ended up being diagnosed with colorectal cancer, and passed 6 months later. So, these things are dear to my heart. They're dear to our family, and the reason we're doing this research is because it has to, it has to end somewhere, right? And so research is the way that we can find solutions. And so now that I can share, I'm going to share my screen now. We started our conversations, Mr. Bradford and I started our conversations around Prostate Cancer Month, and we just couldn't get it in. So, he asked me, said, well, can you talk about prostate and breast? I said, absolutely, because I actually do both in my lab. And so you're going to get a little bit of snippet in between prostate and breast, and then we'll have some conversations about general cancer. And then we're going to end up about really what disparities is and why disparities are important to our community and what can we do about it and why are they persistent. And so, again, if we start to look at breast cancer, right? If you sort of think about the history of breast cancer, and even in the 1975, about 1975 up to 2012, and these statistics still remain today, it used to be more diagnosed in white women, right? So women of European ancestry. But you can start to see that these rates actually increase, and Black women are starting to be more diagnosed. In fact, the rates have caught up, right? So Black women are starting to be more diagnosed with breast cancer than white women. But what was also more alarming is that if you see the right side of that sort of graph is the survival. So now you have the left side being this is diagnosis. This is what we call incidence. The right side is the survival. Who is surviving from this disease? And as you can see, there was absolutely, probably between 1975 and 1985, there was absolutely no difference in outcome, right? Between Black and white patients. But guess what happened? There was an invention, a discovery that there were drugs that targeted, right, certain receptors in these cancers, and those receptors were largely present on women of white cancer. And guess what? That survival curve benefited them and did not benefit the Black community. So this is why research is really important, right, as far as what it means to medicine. So that kind of brings us to the topic, right? Disparity. So, people often ask me, say, Clayton, what is a disparity? So disparity is when a disease disproportionately affects a particular population. And just so happens is that, cancer, and not just, a large number of different types of cancer happen to be disparities. I think breast cancer is largely a huge disparity in now incidence as well as subtype, and we'll talk about what that is. Kidney cancer is another very classical disparity. It has higher rates in African Americans. Prostate, we're going to talk about prostate today, but it's one of the classic examples. African American men are 60% more likely to be diagnosed. Check this out. 60% more likely to be diagnosed with disease, twice as likely to die, right? Cervical cancer as well, and multiple myeloma. And so these are just, types of disparities that are prevalent, but my lab is largely focused on prostate and breast cancer. So when we start talking about breast cancer, a lot of people ask me, what is my risk? How do I know? Well, guess what? 1 in 8 women will develop invasive breast cancer. That means the aggressive kind. That means the ones that we really have to worry about, right? 15% of those cancers were related to alcohol use. 5 to 10% will be associated with mutational profiles. I'm sure most of you guys. So, again, I normally I give a talk to the women and I give a talk to the guys. The women know about the mutations. The BRCA, like this is very prevalent. The BRCA mutations, they know what they are. We talk. It's very pervasive. But if a patient has a BRCA mutation, although they're only in 5 to 10% of the breast cancer cases, if a patient has a BRCA mutation, they're 97% likely to get the disease. It's a big deal. Okay. So this mutational profile is really important. And then another 15% of the women will have a family member with the disease. So that means communities or families with a prevalence of breast cancer or any type of cancer, such as my family, are more likely to be diagnosed with breast cancer. And then obviously we're diagnosing about 2,000 cases of invasive. That means the very, not the good kind of cancer. We're talking about the bad ones, the ones that become very aggressive And it's really interesting, this under age of 45. So if you start to think about it, Black women are being diagnosed at an earlier stage or a more aggressive stage in an early age. And I'm going to tell you now, when since I've joined Hopkins, and particularly after the pandemic, when I talk to our oncologists who see these patients every day, they're extremely concerned because they said, Clay, the Black women are coming in with the most aggressive form, and we're seeing them in their mid 20s. Mid 20s. Just think about having to deal with cancer, a very aggressive disease, when you're 20 years old, right? I don't know if I could have done it. It's very, very important for us to start to understand what the disease is doing in our community. So we start thinking about, again, African American women, have this sort of aggressive subtype, right? A survival rate of 78% versus the 98% compared to white women. The highest death rates, though, in the community, right? And so this is really important to understand what this disease is doing to our families. People start to ponder, what is some of the factors, right? So when we start thinking about disparities, is it income? Is it socioeconomic? Well, you start to look at, there are some differences in socioeconomic status as well, so African American women, but there's still more women who are of European ancestry that have lower socioeconomic status, and it doesn't match the statistical outcomes, right? So that's a really, pervasive thing, that while socioeconomic status, access to care is really important, early detection, prevention is key. So, we still have ways to go and start understanding what this disease is doing biologically. Also, when we start thinking about the survival rate, right? So you start thinking about who is the worst, right? The worst outcomes in survival happen to be in minority populations. I mean, I've gotten several slides in this because I really want to, sort of make the point that, outcomes, these worst outcomes are really pervasive in people of African ancestry or Black women. So what is breast cancer? I think it's very informative. We gotta go too deep into the biology, but I think it's really important to what is breast cancer and the types of breast cancer. So as you can imagine, the breast is made up of ducts, lobes, and bulbs. And these ducts and lobes are primarily there. It's supported through a lymphatic system that's here in green. And that also brings it down to the areola, which is here sort of which is, where the ductal glands are secreted and where milk is sort of delivered. If you start to think about the also areas, if you think about breast cancer, it's supported by a lymphatic system. So as you can imagine, these cells, they need nutrients. So they need circulatory systems such as lymphatics or blood supply to supply to these cells and these particular organs. And that's so naturally supported by the lymphatic system. Well, if you can start to imagine if a cancer arises, right? So this is depicted in red here. And this is sort of what we see as cancer. It's an abnormal growth, largely formed in the duct. We do see cancers developed in the lobular form, but the most common form of breast cancer is ductal carcinoma. So it forms in the ducts. You can imagine that this growth is largely fed by those lymph nodes, right? So that growth is, those cells are outgrowing the normal cells, so they need a rapid supply of nutrients. And so that's fueling them. And then that fuel is coming from the lymph nodes, but that lymph node also gives that cell, as it starts to grow, an avenue to escape and become metastatic. And then that's how they spread throughout the body, right? So you can imagine these cancer cells are very tricky, right? And so this is sort of what it looks like and why it's really important for us to have these tumors diagnosed early. So when we talked about breast cancer, I kept talking about earlier, and I alluded to African American women get the worst kind. So I want to go through what those kind of tumors are, right? So when we talk about breast cancer, we actually are talking about almost 4 different types of disease. And it's all based on the presence of hormones, all right? So one hormone is called estrogen receptor, okay? It's largely developed by hormone receptor estrogen and progesterone. We have another receptor called HER2 right here, right? 73% of breast cancers that are diagnosed are what we call hormone positive, all right? So these hormone positive tumors are those ones I showed you earlier that have that favorable outcome. Guess why they have a favorable outcome? Because we have anti-hormone therapies, right? So if you have a hormone driving the cancer, you target it with an anti-hormone therapeutic, we see very beneficial outcomes. It just so happens that African American women, which only account for 13% of breast cancers, but over 70% of African American women develop this disease, they present without the hormones, right? So it's not a diagnosis of what we are diagnosed or looking for this disease. It's a diagnosis of exclusion. So that means we're looking for the presence of a hormone because we have drugs. They're targeted. But when the African American women present with these tumors that don't lack the hormone, right? And they sort of hit it, we call it triple negative, then we don't have any therapies. We don't have those targeted therapies. And that's a large reason why we have these sort of disparate outcomes, if that makes sense. So you see the triple negative here have these, they're more diagnosed with high grade, they have high poor outcomes, and we're largely left to chemotherapies. Where you see these other cancer types, these hormone receptor positive, this estrogen is ER, progesterone is PR. We have endocrine therapy. We have targeted therapy that we can target growth factors, like trastuzumab, which is a target to one of these growth factors. But again, because triple negative is a diagnosis of as exclusions, that means we're looking for these other receptors. If we don't find them, we group it in triple negative. We don't have a targeted therapy, and we just have to give them chemotherapy. And I think we all know what chemotherapy is like, right? We've heard the word chemotherapy. The second one I wanted to sort of emphasize too is these rates. You know, I talked about it earlier about African American women being diagnosed early. Look at these statistics. African American women, right, compared to European women. Look at those 20 to 34 years of age, 35 to 39, right? Well, we see that not occurring in European ancestry. And then what the survival curves mean is that these African American women who present with this triple negative disease have this worse outcome and the worst survival. So it's really important that we sort of understand this, and I'm glad that you all are here today because we're all going to leave here being empowered to do something about this. We not only see that it's African American women. So a colleague of mine, she's a very one of the most famous African American surgeons. Her name is Lisa Newman. She's at Weill Cornell. So we're going to talk about some work. I do not only work in the U.S., but I largely do work throughout the diaspora in West Africa. So Lisa does work in West Africa as well. So what Lisa asked the question was, and this is Dr. Newman, excuse me, if it's so pervasive in African American women, do we see this in Native African? And the question is, the answer is yes, absolutely. African American women or women of African ancestry in West Africa, particularly in Nigeria or Ghana, present with this triple negative disease very similar to African American women. So it's not just associated with, U.S. factors. This is clearly something that has to do with genetics, genomic backgrounds, and we're going to talk about that, what those origins could be in a little bit. All right, I'm going to transition because I'm not going to keep it too long. I'm going to transition to the brothers for a minute. All right, guys, we're going to talk about prostate cancer. And this is really important because usually when I give these talks and I talk to the guys in the room, right, guys don't want to talk in front of the ladies. Guys usually want their own conversation. But I titled my talk Man Up for Prostate Cancer because we got to get over that. We have to be able to talk about this disease. We have to be able to talk to each other, and we have to acknowledge that this is a problem, and it's a problem in our community, right? And we got to do something about it, and we got to be empowered so we can do something about it. So I titled this Man Up, all right? And we man up because guess what? We're important, right? We need to be fathers. We got to be brothers. We got to be sons. We got to grow up to be fathers. We got to grow up to be granddads so that we can pass on these generational knowledge, right? And this disease is taking us out. So we got to do something about it so that we can continue that, particularly in our families. So we started talking about prostate cancer. I talked about it early on. We talked about disparities. But here are the facts. 60% African-American men, I highlighted it here for you. African American men are 60% more likely to be diagnosed and twice as likely to die. Every 100 minutes, an African American man or a man of African ancestry is being diagnosed with this disease. So that means by the time we start this call and finish this call, and you guys get a little bit of dinner, somebody's going to be diagnosed with prostate cancer, right? It's a problem, and it's something that that we can do that's avoidable. So what is prostate cancer, right? So it's a malignant growth, right? It's a malignant growth. It occurs in the prostate gland. I'm gonna show you, just like I showed about the breast. I'm gonna show you in a minute what that looks like. However, if we diagnose it early, men usually go on to have a very healthy and fulfilled life. However, if we diagnose it late, that means it leaves the prostate and metastasizes, just like we talked about in breast cancer, and it leaves that prostate. That's when we have very limited options. The options are very limited, and the survivals work. We call that leaving of the primary origin of which a tumor developed. We call that metastasis. That sort of word here in the middle. All right, and that's when we don't have any curative therapies. So where is the prostate? So unfortunately, guys, this is a gross anatomy sort of view of the prostate. It's sort of located right beneath the bladder. So if you think about the bladder, which we feel is here, is superior to the prostate. You sort of look about what's low. Do you see these sort of tubes that are going through the prostate? That's the urethral gland. So that's where the bladder empties into the urethra and out through the urethral cavity, right? And then we urinate. So the prostate is this sort of walnut gland, sort of snug right in there, right? Now you can imagine if that prostate starts to grow, two things could happen. One, it's going to squeeze that urethra, right? So you can sort of see. So you see these little urethra. So what'll happen is, guys, it'll be hard to urinate because the urethra is being squeezed because the bladder can't empty properly. So that bladder is not emptying properly, so it's squeezing on the urethra. The second thing it can do is it can push up on the bladder, right? So if it pushes up on the bladder, guess what happens? You got to go more frequently because the bladder can't feel now. So so if the bladder can't feel, right, then you would have to go more frequently. And if both things happen, that means the urethra shrinks and the bladder is being pushed up as well. That means you have to go and you can't go, you're in bad shape. Does that make sense? So that's why it's really important. Now, I started off by saying this before, but I'm really going to make my point now. Unfortunately, the prostate is the only gland we know, men, at the age of 40, it starts to grow. Every man's prostate is going to start to grow when you turn 40. You got two choices. It can be benign growth or it can be cancer, but it's going to start to grow. So that's why we say, Lordy, Lordy, you turn 40, your prostate is going to start to grow. Okay? Now, it can be benign growth. And for majority of the men, it's going to be benign. We call that BPH. We call that benign prostate hyperplasia. Okay? If it's cancer, though, it goes through several stages. First stage, we call it prostate interepithelial neoplasia. That's a whole lot of words to say early stage cancer. Okay? So it's just really early stage. This is when we want to catch it. PSA's up just a little bit, really high, elevated. It's early stage disease. We go on to either treat it, take it out, people go on to resume a normal life. Okay? Prostate cancer, that means that early stage cancer is now full-blown disease. Okay? A little bit more serious, but still many options available. We're going to talk about what those treatment options are later. All right. But if it goes to something we call prostate cancer progression, now we're starting to become limited, okay, in the things we can do. Because that means that prostate is going from that walnut, probably like now an apple or an orange, the size, is probably ready to leave the prostate and go to other organs because it's used all the nutrients in that area, right? And so therefore we have limited options, right? So this is what metastases look like. All right. So this is going to be my last biology slide. I promise. But I think it's really important because I want to show you. All right. So these are cancer cells at the top over here. Excuse me. These cancer cells are really sneaky. They actually learn how to break the barrier of your blood vessels. They learn how to enter the blood vessels, circulate, gain access to your entire body, and then learn how to leave the blood vessels and go set up another tumor in a distant site, such as lung, brains, bone, or your lymph node, and start all over again. That's metastasis, and that's why it's hard to treat. Does that make sense? All right. That occurs in both prostate and breast. All right. So who's at risk for prostate cancer? These are the risk factors. Age, because remember, first thing we talked about, every man's prostate is going to start to grow. So age is a risk factor. It can be benign growth, it can be cancer, but age is a risk factor. Race. We talked about African American men, 60% likely more diagnosed, twice as likely to die. African ancestry, diet. We know a healthy diet helps as well. Lack of physical activity and family history. So we talked about age here. So prostate cancer incidence rapidly increases after 50. 70% of tumors are diagnosed after the age of 65. But particularly for Black men, you should start getting your PSA anywhere between the age of 45 and 50. Okay. However, a 70-year-old is likely to die from prostate cancer, more likely to die than a 50-year-old. Again, because this is an age-related disease. I'm sure you have questions of why our former President Biden, at the age of 82, was diagnosed with prostate cancer. I'm gonna save those for question and Q&A in the end, but we're gonna talk about what that looks like and why that anomaly occurred. We talked about African ancestry as a risk factor. So prostate cancers in African Americans are highly more likely to be diagnosed and twice as likely to die. Again, this is a classic disparity, and it's something we can do something about. So for the remaining couple of slides, I'm just going to talk about disparities in some of the causes, right? And then we can get into your questions for the Q&A. I like to put this up here. It's another busy slide. You know, we're scientists in clinicians. We like to put busy slides, but let me walk you through it. Disparities there's not a single cause. And what this slide tells you is that when we think about disparity, there's so many factors that have to be considered. One, healthcare access. Regardless of ethnicity or even ancestry, if a patient is diagnosed early, you get in and see your doctor, you're being monitored, you have a better chance and better outcomes. Access is a major key, right? So we put access at the top. But we also see awareness. All of you guys are on this call today. That means you want to be aware. So being aware is very important, but aware actually goes to access, because people who are aware actually take advantage of the healthcare system and use it to this maximum benefit, and they usually have more favorable outcomes. I don't have a lot to talk about, but I do another talk called the difference between race and ancestry. But race is a social construct, right? But ancestry is what your genes are. And there are differences, and we see these differences manifested in how the tumors sort of present in the clinic, right? Race is something that's societal. Ancestry is something we inherited. But all of these factors sort of play a role. And then the quality of care. It's not just being access, it's also the quality of care. The quality of care is just as important as being accessing care, making sure that you're getting the standard, not suboptimal care, but the standard, the optimum, the latest and the greatest that we have to offer is what medicine can offer, that you're that's being offered and you're assessing. That's also very, very important. So these are the major factors that we think that that create disparities, but also can help reduce disparity. So we also think about genetics, right? So I kept alluding to the genetics, right? So these genetics, we think about 30% of tumors right now are caused by your genes, right? So that's a pretty substantial amount, right? 15% are social circumstances, 40% is health, behavioral health. That means the behaviors that we do, the health behaviors, right? And 5 minutes is associated with environmental exposure. That means what you're exposed to, if you live next to, some environmental toxins and so forth, right? And then 10% being that what we talk about suboptimal care, okay? And so with this being this sort of continuum, I think it's really great that we start to understand this. So for the remainder of my talk, I'm going to talk about genetics. So when we started talking about, I showed you that nice, beautiful, picture from our colleague, Lucy Newman, where she said, hey, are Native African women being diagnosed the same thing as African American? And the answer was yes. And so we think there are some genes that are that can be traced through the African diaspora. And I do a lot of research. I work exclusively in West Africa. I've actually been to Nigeria twice this year, and I'm going to Kenya in a few weeks. Is what we've been doing is sequencing Native African and African Americans and trying to understand the missing link between what is really causing this pervasive disease. And just so you know, some of these BRCA genes keep coming up as some of the most genetic factors that associated with African American and African risk, and both prostate and breast, not just breast cancer, prostate cancer, men too. We see these BRCA mutations sort of driving disease. Why is this important for us to sequence? Well, guess what? All the new drugs, and I'm gonna talk about a slide that are being developed now. These sort of targeted therapies. These we're trying to move away from chemotherapies. We're going to targeted therapies. They're all based on genes. But guess what? The genes, the data we have is mostly from white individuals. We don't have enough genes sequenced from non-white individuals. And let me show you what that looks like. So you see this sort of orangey curve. This is all the genes, the amount of sequences we have from Europeans. You could take everybody else, Asian, African American. Oh, African American, it's hard for you to see. You got to squint our eyes down there to see that at the bottom. And definitely African American, Hispanic. That's what we represent as far as the amount of information available for scientists like me, my colleagues who sit next to me every day at Johns Hopkins, one of the world-class research institutes in the world, who are making medicines every day. They're utilizing that European genomic data to make the drugs. If we don't have the African American and African ancestry drug genomes in there, you won't get accounted for. It won't be there. Why is this important? NCI, the National Cancer Institute, did a study. Okay, they call it the precision medicine trial. They wanted to take 10,000 patients and match them based on their genome sequencing with the corresponding drugs. They call it the NCI match trial. But guess what they found? Over half of the 10,000 patients, when they sequenced the tumor, did not have a drug that matched. Half. So we have made all these new therapies that target all these genome sequencing, these drugs. It costs $1.2 billion to get a drug to market, from discovery to market. So we spent $1.2 billion developing new therapies, and half of the patients that were sequenced did not match. So they did not qualify for those therapies, right? It's a problem. So this is a quote from me. If you don't take home anything from me, is if a population isn't involved in research, they may not have benefit from the advances. This is what we live by every day, and I think it's really crucial. Okay. So I want to end with what I think is some of the advances in medicine today that I think that benefit African Americans, and some favorable outcomes when we get people on the right therapeutics. There's a new wave of therapeutics called cancer immunotherapy, right? I don't know if you guys have heard this, but again, as I mentioned before, we're moving away from chemotherapy and we're moving into the age of targeted therapy. And so in this targeted therapy, we're now understanding that the immune system, if directed appropriately, can go in and fight cancers. All right. And so this next generation of treatment are called immune therapies. And these immune therapy are saving and changing lives. And again, what it does is it harnesses your immune system that has been turned off by the cancer cells. Now you can imagine cancer cells are really smart. So when cancer is developing, your body is supposed to detect that and say, hey, let's eliminate it before you even know it's a problem. But guess what the cancer does? Cancer says, hey, immune system, there's nothing to see here. I turn off the recognition pattern genes so that I can go undetected. Well, immune therapy turns it back on, right? And now the immune system can go in, your body can go in and start to fight these diseases. And we're seeing amazing, amazing outcomes, by utilizing these sort of immune-based inhibitors. We have several main therapeutics. One of the two ones for breast cancer are called Opdivo, and the most latest one is Keytruda, which is here. I'm sure you've seen the sort of advertisements. Well, Keytruda is one of the most important therapies. It's been approved for triple negative breast cancer, so we do have a targeted therapy. They are these receptors that are on the surface of your immune cells, right? And when they're targeting these immune cells, it turns it off so these T cells can go in and do its job. Now, Keytruda targets this receptor called PD-L1. And guess what? We published some data that shows that African American women have higher PD-L1. So with some work, some colleagues at Hopkins, we're now planning to open up a trial that we're overly enrolling African American women, right? So that we can make sure they're getting the right drug to match their tumor and the biology of their tumor. And this is where our research is meeting clinical interventions and that we're getting the right patients on the right drug at the right time. So when I started thinking about clinical trials, people say, well, Dr. Gates, I don't want to be a part of an experiment. Okay. Well, in the case of cancer, it's not like this in all disease, but in the case of cancer, in a clinical trial, it is illegal to give a person an experimental drug or without the standard of care. So what that means in lay terms is that you'll never get the sugar pill. You'll never get the placebo. We have to give standard of care. That means whatever is approved plus the new drug that's being tried experimentally. Everyone is ethically charged, every physician, every hospital, every physician that is developing or running a clinical trial is ethically charged to give the standard of care. So that means you will get whatever is FDA is approved plus the new drug. The second thing is you cannot get not qualify in the case of cancer for a clinical trial until you have failed the first therapy. So that means that everyone who is newly diagnosed has to get the first drug. And if that tumor did not respond, right, that means that patient did not respond, then you get the second therapy. That means to add something. Then the patient's probably qualified for a clinical trial. So we're not doing the placebo, the super drug. And again, this was largely, from the Tuskegee experiment. I spent 17 years at Tuskegee before. All of these ethics are in place and they're being monitored, right? And if you want to know where clinicaltrials.gov, I'll give you the link at the end of our presentation. If you want to know if a clinical trial is ethically sanctioned by the FDA, it'll be in clinicaltrials.gov. If it's not in clinicaltrials.gov, I don't know what they're doing. I can't vouch for it. Okay, that makes sense. And then the last slide, I'm just going to tell you, we have gotten it right. So I partnered with, from research that we did in our lab, with a company called Demeron. Demeron was utilizing immune therapy in prostate tumors. Well, guess what it turns out? European men who present with prostate cancer don't have any immune markers or cells in their tumor, but African American men do. So we published a lot of data. We were able to enroll African Americans in a clinical trial with the right drug. And guess what? This little line here says African American men respond better, right? And they have a 12-month survival advantage when they're on the right drug that matches the biology of their tumor and not just on a drug that was just made for the general population. Okay, so we have successes. We're forging new successes every day, and I'm happy to take any questions from you that or any thoughts you may want to share. And thank you.
Can we just take a minute and celebrate the scholarship that is Dr. Clayton Yates? Can we just take a minute and celebrate? I don't think I have ever heard a presentation this clear about this topic. And so I just want to celebrate you, sir, for the work you're doing, right? It is imperative and it is important. I'm encouraged those who are watching, if you have a question, put it in the chat. And I don't know, Dr. Yates, if you saw this, but there are several people in here who are cancer survivors, right? In fact, there is an Eric Dunlap who is very excited and is a survivor, 25 years of male breast cancer. And so we are thankful for the work that you're doing. Now, you mentioned something while they're formulating their questions about this low percentage of African-American genome sequences.
That's right.
What do you think is an indicator or a cause of the low number?
Awareness.
Awareness.
So two things.
Okay.
So we're now moving into where it's starting to be offered in the clinic. However, prior to when we were in the research well, it was the investigators. If you don't, just to give a little bit of background. So me as a scientist, I go in, I have an idea. I'm charged to with an idea. I write, get funding for it. I research things what I know. So if I only want to focus on European ancestry individuals because that's what my focus is on, then that's what I would do my research on, and then that's what it'll get published. And then those data will get picked up by other individuals, and then they will be used. The pharma companies will use that to start developing drugs, and so on and so on. And then what happens is communities, underserved communities, get left out, right? So that's what happens in the research world. And then in the second world is we also have a lack of representation in clinical trials. So, now I actually think it's unethical in this day and age for us to just enroll minorities in clinical trials without understanding if their biology, if their tumor matches the clinical trial. And I'm telling pharma, and I'm very, very clear about that because we have the capabilities. But 10 years ago, we weren't sequencing everyone. We were just kind of enrolling in clinical trials, and we needed more minority participation. In this day and age, in the precision medicine, precision health platform, there's no reason we can't have your gene sequence. It does not even cost that much. 23andMe, pretty sure most people have done it. We can understand what those mutations are, and we can match that to the appropriate therapy.
Oh, wow. 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 Thank you for that. Thank you for that. It's very important that what you said earlier, you said if a population is not involved in the research, then more than likely they won't benefit from the advances.
That's right.
And this may be part of that. There are a couple questions in the chat that I kind of want to bring up. First question has to do with colon cancer as a genetic disorder in women. And you mentioned 2 to 3 women in your life that had colorectal cancer.
Right.
So what do you know about colon cancer as a genetic disorder in women?
Yeah, we absolutely see that. It's not just women. So it's sort of grouped into women and men. And what we're seeing now, I actually have a junior professor who's taking this up as her career. She's starting to look at what we've seen early onset. So we're seeing more African Americans present with earlier onset colorectal cancer. And they're having these mutational patterns that are just kind of different, right? So and I can, tell you what those mutations are. They're KRAS. We see this sort of microsatellite instability, patterns that sort of basically taking the brakes off the disease and starting and allowing it to grow really aggressively. And we're calling it early onset because again, it's, colorectal screening now, you should, probably around the age of 50. These patients are presenting again, late 20s, early 30s. So it's early onset disease. And because it presents early, it's much more aggressive. All the brakes, almost like the triple negative disease, like I've kind of mentioned, the brakes are gone and they're just, skipping steps and going so aggressively. So it's a real problem right now.
So does that mean you're encouraging, or are there populations identified that need to do their first colonoscopy a little early, or colorectal screenings earlier than 45 or 50?
Yes. And so the current guidelines now are if you have a member in your family that has a genetic history, you qualify for early colonoscopies. Okay?
Yeah.
So
Okay.
those are the guidelines. Now, most doctors, if you, kind of talk with them, they'll work with you. They'll ask you, "Hey, somebody, can you remember somebody?" Okay. Can you remember someone in your family? Especially if you feel like your family has other types of cancer, they'll kind of work with you to get it. But that's how you kind of get the insurance to pay for it. But right now it's family history for early diagnosis is a predisposition for disease, which means genetics, right?
Wow. So this is amazing, and I'm gonna get to this next question. But how do we challenge the families that don't talk about their medical history, right? Or that don't talk about, or they fallicize about why auntie or big mama passed away, or daddy and mama, and as a result, they can't present a clear medical history.
Well, I can only tell you what I've seen and kind of somebody in the family got to step up, right? So it's usually a senior elder member that says this is important and it's something we're going to discuss. it's a reason why prostate and breast cancer is right before the holidays, because these are discussions we should be having at the holiday table, right? When Thanksgiving, these are discussions. Again, I would not have had the career I've had if I did not know my grandfather passed of prostate cancer. Again, I was 13. That wasn't something we talked about. I asked, why did grandpa pass? And so then it became, about prostate cancer. And then I dedicated my life to sort of understanding why. But that why could have just also been, me getting early screening or making sure everybody else in my family's, health was taken care of well, even if I didn't choose this life, right? But understanding that and what would happen, particularly from your family members, makes it important to each individual.
Amazing, amazing. Another question: are the risk factors heightened for men having breast cancer to having prostate cancer?
Well, so it's unfortunate because breast cancer in males is rare. So we don't know a lot about it. We just don't know a lot, right? We know a lot about prostate cancer because of those statistics. 40 years old, your prostate is going to grow. It's either benign growth or cancer, one of the two, right? So we know a lot about that. But we just don't know about a lot about the risk factors for male breast cancer. We see it, but we don't know about the risk factors because it doesn't present as often as it does in women.
I think he may be asking, because he is a breast cancer survivor, if that will increase his risk for prostate cancer. Is there any linkage to one cancer increasing the risk for another?
Oh, okay. I'm sorry, I misunderstood it. So we don't have any direct links, but let me just kind of get both of them are hormonally regulated, right? And both of them have a genetic component.
Okay, okay, good. So they both are hormonal regulated and they both have a genetic component.
That's right. Prostate is regulated by testosterone. Breast cancer is usually by estrogen or the lack thereof. So, and then obviously the mutational genetic sequences also play a part in the tumor development itself in both diseases.
Okay, okay. Have a young lady whose husband passed away from liver cancer that spread to the lungs and affected his kidney, caused fluid in his stomach, legs, and feet. She has a question: can treatment cause the cancer to spread faster?
We haven't seen any treatments cause cancer to spread faster. There's some anecdotal data, about surgeries, and only because when you sort of, have a surgical resection, if it's somehow maybe, not the surgeon missed it or didn't get it all. And again, I don't think this is malpractice. You can imagine surgery is there's a large level of inflammatory response. I just talked about inflammation is like go-go juice for these cancer cells. So that kind of makes it spread. So it's not the surgery itself. It's kind of like the inflammatory side effects of that if it's not gotten all this sort of spread. But we have not seen any evidence around any standard of care. Because again, remember, a drug does not make it a standard of care unless it's rigorously tested in phase 1, 2, 3, and phase 4, right? Large populations of clinical trials and deemed to be safe.
Okay, okay. Thank you for that. Final question that is listed is, is there any medication or standard treatment for stage 4 colon cancer?
It's a little tough. Once it becomes metastatic stage 4 disease, that's the time when we start thinking about clinical trials. That's the time we're really thinking about something experimental, that you would get whatever the standard care plus something experimental. And so, because we're out there in the unknown, that we don't have any real good data of anything that's really effective in stage 4 disease.
Okay, okay. Oh, okay. Can people get cancer in the uterus if it's a small lump on your uterus?
It's very possible.
Very possible. Should be checked out.
Should be checked out, yeah.
All right. Can you speak on early intervention for youth with conditions like PCOS and what steps should be taken to address it?
Education, again, it is hard to go into, specifics, on every topic, but education, if you have a family history, then it's really important to understand those and be in constant contact with your physician and your doctor.
You said something earlier about, and you mentioned reference, right? President Biden at 82.
Yep.
Right. What do you say to the person who is 70 and older? Because you mentioned that there is a large identification that happens after 70,
Yeah.
right?
Well, between the age of 50 and
Between
70.
50 and
Usually
70.
yeah.
So what do you say to somebody who's 75 and older or 80 and older who feels the enlargement, may have the bladder issues, but says something like, I've lived my life, there's no need in me going after it? Is there hope for someone who is identified or who gets diagnosed in their later years?
So diagnoses in the later years, all the options are available to you if you're healthy. So health is a big factor, right? So just we're talking about otherwise healthy individuals, right? All the options are available. The problem is the guidelines say we stop screening at 72. Because of that first factor. Every man's prostate is going to grow. So the guideline says is that the prostate growth from the age of 40 to 72 never became cancer. And so therefore it's not likely to be cancer. And so therefore we stop screening. Okay. Now, in the case, and that's why even our former president, was not being screened.
Yeah.
But he had prostate cancer. And so when that occurred, people said, people all in the news, well, Joe Biden got prostate cancer. Joe Biden got prostate cancer. How did he get prostate cancer? All of us said he already had prostate cancer. He had it for a long time. They weren't looking for it. Does that make sense? So all of us knew it had been there for a long time.
But they hadn't looked for it.
But they hadn't looked for it because the
years.
guidelines, even the guidelines for Walter Reed Hospital, the world's class physicians, our colleagues right down the street, those are not the guidelines.
Gotcha.
But in prostate cancer, what we have what we call shared decision makers. So if you request it early or late, they have to give it to you and be covered by insurance. But if your doctor follows the guidelines, if you listen to your doctor, this is why it's so important. Prostate cancer is a little bit nuanced because we do have something called shared decision making. So the treatment options, whether you get PSA screen or test, is a decision that you and your physician make, not just your physician. So you can absolutely. I was at a men's integrity breakfast during prostate cancer month. Man, 80 years old, had his prostate out, had his therapy, still, and was happy he did. Okay, because he said, I elected to keep being screened and being tested because I wanted to know. Some men don't want to know, some men do it. It's what's called shared decision making. You have the right to make decision. And what that shared decision does is that if you request it, the insurance will pay for it because you have as much say so as the doctor.
Oh, that's good to know. That's good to know. That's good to know. Shared decision making.
It's called shared decision making.
You have as much say as the doctor. You request it, it should be covered by the insurance.
That's correct.
Okay. So with stage 4 cancer, colon cancer in women, it's still something they should talk to their doctors about, right?
Yeah.
And because you can't, and like you said earlier, you can't case by case make any diagnosis or determinations. That's something that they should pursue with their doctor.
That's correct. But again, stage 4 is when we don't want to be. We're at the limited option stage. Miracles happen every day. That's why we have clinical trials. We see things happen, and so I'm not saying to give up hope, but we want to avoid that stage 4. Stage 4 is usually highly aggressive metastatic disease. Most patients who are even at stage 4 have failed some type of first-line therapy already. And so we're in the experimental stage.
Gotcha. Well, any final words before we end it? This has been an amazing time. Listen, I have your number and I want to introduce you to another platform in the future. But any final words of advice that you have for us, parting words of encouragement? You've already dropped some nuggets. I've already posted some quotes on Facebook because you just dropped some bombs on us. And so, what would you say in parting, sir?
I just want to tell people your health matters, right? It matters a lot. I know we're busy. I'm busy. I have to tell myself these things because we're all human, right? These are real human things, but it matters. And so, taking care of yourself, your health, particularly in this time with prostate cancer and breast cancer awareness month, is a time for us to renew that sense of commitment to health. And even if may not have been as diligent, it's still time. You still got time, right? We give us that time to take hold of the reins and do something about your health. And so that's my leaving sort of message. There's hope. And I also want to know somebody's out here fighting for you. That's what we do. What I'm doing on the front lines every day. We're out there fighting for you, so that you also have something when you get there to the clinic, to the doctor as well. That's tailored for you.
Listen, we want to thank everyone for being on and listening. We also want you to heed the words that he said, right? There is hope, health matters, and there is someone fighting for you. In fact, if I could go biblical, right? Deuteronomy 20:4 says, the Lord your God is he that goes with you to fight for you against your enemies to give you the victory. God is using doctors like Dr. Yates and the John Hopkins research staff to do just that, to identify the aggressive cancers, to deal with the disparities, and to find solutions that address them so that your life is preserved, is healed, and that you have an amazing quality of life. So listen, thank you for joining us. Thank you for being a part of this. You will see it on Facebook soon. Share it with someone you care about. And if you have any other questions, you can reach out to me, Napoleon Bradford, at napoleonabram.com, napoleonabradford.com, or at Napoleon Abram on social media, and I will relay the messages and questions you might have after this. Blessings to you. Carmen, thank you for the connection. And listen, TUSKGEE is what was said to you, Dr. Yates.
And what the reply is right?
You know. Okay. I only do that with Phi Beta Sigma, but I guess I can extend it to Tuskegee for the day. Blessings to y'all. Y'all have an amazing day.
Thank you.